So welcome everyone to the last trainee rounds presentations of the T-CAIREM Summer Research Program. My name is Samantha Unger and I am a T-CAIREM Education Trainee Affiliate, and I'm a PhD student in biomedical engineering where I look at designing wearable devices for monitoring cardiovascular health. We also welcome our adjudicator for today's session, Girish Kulkarni from University Health Network. Today we'll hear from two trainees. First, at 12 to 12:30, we have Faezeh Lotfikazemi, whose research focuses on an AI-driven needle-free OS-CMR for classifying ischemic, non-ischemic, and edema patterns, a novel approach with pathological feature mapping. And then following that, from 12:30 to 1, we have Kejah Bascon looking at an AI-amplified health equity, investigation of individualized patient education materials on comprehension, satisfaction, and trust. So we will dive in with our first presenter. Faezeh Lotfikazemi is a PhD candidate in experimental medicine at McGill University under the supervision of Dr. Matthias Friedrich and has a background in biomedical engineering and computer science. Her research focuses on developing advanced AI algorithms for analyzing oxygenation-sensitive cardiac MRI. That's OS-CMR. And so over to you to begin your 20-minute presentation.
Thank you, Samantha. And just let me share my PowerPoint. Good afternoon, everyone. I'm Faezeh and PhD candidate at McGill University and excited to share a research project, Edema, which classify and visualize myocardial pathology and provide the first strong evidence that the OS-CMR contains sufficient information to mimic T1 and T2 and also LGE feature. So the cardiac MRI or the CMR is a gold standard for assessing heart morphology, function, tissue composition. So we use multiple sequence like CNA for function, T1 map for fibrosis, T2 for the edema, and LG for scar. But however, each of these requires time, patient cooperation, and often contrast injection for the LG, which not ideal for every patient. So what's the solution? So for make MRI safer or faster and also cheaper, we develop oxygen-sensitive CMR in our lab. We call it OS-CMR. It's a contrast-free method, sensitive to myocardial oxygenation change. It's based on bold imaging and breathing maneuver. And so previous study, as I show here, show that the OS revealed vascular and metabolic abnormality, especially in heart failure patient. But the question is, can we go beyond just oxygenation, and can OS-CMR replace some of this diagnostic information we usually get from the contrast-based imaging? So that's what we set out to explore in my project. And so this slide introduced the motivation behind our work. These are my popular paper in 2022. The Jean proposed the VNEs of deep learning method to generate LG-like image using multiple input like CNA, T1 map, and the contrast enhanced scan. And it's show promise in HCM and MI case, but it still depends on the contrast and the multiple sequence for training. That's got us thinking that what if we could do all that using just one native contrast-free sequence? So the OS-CMR is already reflected the oxygenation change linked to the ischemia, edema, fibrosis, is faster, safer, and require no injection. So our hypothesis was, can OS alone carry enough information to help us to classify this different myocardial injury without needing the injection? So this is show the core of our method. We trained DeepOxyMap using native OS-CMR image to classify 4 types of myocardial tissue: no injury, healthy, ischemic injury, non-ischemic, edema, and we test several architectures and found that the VGG19 performed best with an AUC It's about 96. And to go beyond the classification, we look inside the model, like into these so-called black box, and extract the heat map, which highlighted the region that the AI focus on when making decision, And we then compare this heat map with the expert contour that they use it on the LG for the scar and T2 for the map, which I'm gonna show you in detail. And this pixel level comparison confirmed that the OS contains this meaningful pathology information, and our model can not only just classify, but can accurately localize this pathology pattern. So let's start with the data preprocessing step. We start with 190 cases, followed by data cleaning and preprocessing. We have three main groups, as I said, ischemic, non-ischemic, and inflammation. To make sure these was no overlap between this category, we use strict inclusion criteria. Like for ischemic, as you can see here in the example, include patient with clear AG pattern consists with infarction. Like in this example, you can see this scar is like the bright area in the LGE and like the red in the T1. But for the non-ischemic case, here, this example, we again rely on the LGE, but make sure to rule out the edema and ischemia cases. And for the inflammatory cases, we include patient with T2 map-based evidence of edema, but no fibrosis or scar. So our case was reviewed by the expert cardiology that we have in MUHC hospital. And yeah, so after that, now let's talk about the architecture beyond the depoxy map. We built on VGG19, which significantly outperformed the other popular model like the ResNet efficient net, and it's achieved AUC of 96, especially strong and distinguish between the ischemic and non-ischemic cases and the edema. So for further improve the model reliability and clinical value, we add myocardial. I'm sorry. We add Monte Carlo dropout to estimate the prediction uncertainty and five-fold cross-validation to ensure consistent performance across different data split, and also use residual connection to enable like deeper and more effective feature learning. So these are these enhancements made model not only like accurate but more robustness and interpretable. So as I said, we use this different technique, and the best metric that's the best performance that we get is like for the well accuracy, we reach about 81 and AUC of like 85, and but all of these just gets from the classifier just trained on OS-CMR alone, not the LG, not the T1, not T2. And so we not just stop that. This slide show how our model go beyond the classification. It's actually localize the region of the myocardial injury using the just OS. So as AI developer, we always ask what happened inside the black box. How does the model decide where the pathology is? So the answer is that we extract the feature map from deeper layer of the network and convert them to the heat map, highlight of the region of the AI found important for each prediction. And we then compare those AI generated heat map with expert draw contour that they copy directly from the match LGE for the SCAR, for the ICM and ICMP, and from T2 for the edema, and all on the like exact OS-CMR slice that the AI was trained on. So as you can see here in the right image, the yellow region show where the AI focus and they match the ground truth like very well. And but we didn't stop like visually just check it. We made this comparison quantitative by turning both the AI heat map and the expert contour into the binary mask. So to allow for pixel Y evaluation. So in the left, you can see the result that we get like for the test, like dice. It's about 83 for ischemic, 70 edema, 89 for non-ischemic. So in short, our model doesn't just classify. It's it shows the meaningful pathology from the native scan, from the contrast free sequence that we have. Uh, and let me go to the next slide. Yeah, so I'd like to take a moment to highlight how we expanded our work after we discovered that the OS encode rich pathology information closely reflecting the LGT1 and T2 pattern. So we developed a novel organ to synthesize T2 map and T1 parametric map for T2 for the edema and T1 for the fibrosis cases. So we didn't stop just checking the SSIM, PSNR, FID. We go to check the clinical like validation. So I'll be happy to explain it in detail at the end of the presentation. But briefly, first, we not just synthesize the myocardium, we could synthesize the whole short axis of the MRI. And we check if there is a signal intensity and the signal intensity are similar with real and generated image. And then we create an RI in the edema area and like in the healthy and create the T2 curve and then comparatively quantitatively this T2 curve together. And also we did the EPG simulation for the to simulate it again the T2 curve, and we check if they follow the same pattern. And we did the same thing for the T1, and we synthesized the T1 parametric map from the OS, check the signal intensity, check the T1 curve, and also you can see at the end the T1 map, the color map, which is very promising. So at the end, as a conclusion, our algorithms can extract feature representing T1, T2, and AG from native OS-CMR. AI heat map accurately visualize myocardium pathology, tissue pathology, and the organ at the end can synthesize T1 and T2 from parametric map from native OS-CMR imaging. And in combination with information on myocardium oxygenation change during the wasatile maneuver, this unified framework may enable an ultra-efficient, comprehensive, needle-free, and clinically relevant diagnostic tool for assessing myocardium disease and injury. So thank you for listening. And I'm so excited to hear your thought, your feedback, your comment, and big thanks to my supervisor, to the great, amazing CMR team.
Amazing. Thank you so much for your fantastic presentation. We'll
Yes.
now move on to questions from our adjudicators. Garish, if you'd like to take a chance and go first with a question, you may.
Sure. Faezeh, that was a really nice presentation, and I can see good clinical application. Um, just to be clear, in terms of the generation of your algorithms, were you using pre-existing MRIs that have already been obtained, or was this prospective? That wasn't clear to me.
It was prospective study, but we have report on the OECs in clinical, paraclinical, and clinical information. But to make sure that I classify the category without overlapping, by help of two teams, the Dr. Jawad and Dr. Leila and Dr. Chetrit, we like classify the case with like ischemic, non-ischemic, and the edema again to make sure there is not overlap between the different class.
Okay. And
Yeah.
I guess that was part of my next question, but a sub question there then is how good is the model at distinguishing the subcategories like ischemic versus non-ischemic fibrosis? Because scar fibrosis is basically the same thing in my mind as a clinician. So like you had four categories. How good was the discrimination between if you did a pairwise, one versus two, or one versus three, one versus four, or do you not have that?
Yeah, the ischemic scar is mostly like localized and
Mhm.
like the near the myocardium, but for like HCM or like DCM, they are like inside all of the myocardium. So
Okay.
for the network is finding the ischemic is more like simpler, and especially because when in the OS, when we have the scar, the myocardium getting narrowing like compared to the healthy one. So that's why the model could find the ischemic like better, as I show in the table, and because I checked the AUC like in different category of my classification, and it's proved my idea. But still there's challenge between the edema and non-ischemic. But so that's why I will make sure that we like not input the edema
Mhm.
cases into the non-ischemic. But yeah, when I check the metrics, it's like let me see, what was the number? Uh, yeah, it's like for the class, it was 94, 80, 80, 93, 98 for like different class that I have. Yeah, these are the number of my like AUC.
Okay. Um, Samantha, I have more questions. Should I let Matthew ask or
I was
anyone
gonna
else?
say
Yeah. Okay.
we'll let him ask first and then we'll
Yes.
circle back.
Okay. All
We're
right.
joined by another adjudicator, Matthew Schlenker, as well from University of Toronto. Matthew, do you have any questions for this presenter?
Uh, sure. Thank you first. That was an excellent. I'm happy to be part of this, and that was an excellent presentation. Obviously, not in my area, because I deal with eyes, so that's good and bad, I think, sometimes for these. I want to make sure. I guess I have a few questions about it. Some are just general questions. How confident are we in the gold standard to make this comparison with your model?
You mean the LG that we use?
Yeah.
The LG is gold standard for like in the cardiac MRI for the scar, because if you like remember the image, the when we use the injection, the injection goes to the myocardium, and if there is like abnormality inside of the myocardium, this injection material was like stick inside of the myocardium, and when we take the MRI, that's abnormal area was brighter than the other area in the myocardium. So that's like the gold standard that we use for the scar,
Hmm.
and for the T2. We have abnormal and normal value that we use in our lab. Like we have a table that if that area was like go beyond the a normal is show up like in blue area, and the T2 map which indicate there is an edema.
Hmm.
So yeah, these are the gold standards I use like based on the clinical report we have. Yeah.
Right. And that's where, so I like that. So I think it's important that we have a really good gold standard to compare against. And I can tell you in my field of work, our problem is we don't have good gold standards. And B, it sounds like, you just explained kind of how we're able to use the gold standard. And I think sometimes, and again, I'm not familiar with this model in particular. I think we've had instances where an AI, it's kind of like a black box, right? And it spits out an answer for us, and we don't know what's driving it. Here, we know what should be driving it, right? Because you're doing the injection and you're seeing. Are there ways within your modeling where we can make sure that the AI is actually reading the things we want it to? And I'll just give you an example. This is from a long time ago and less sophisticated, where an AI was actually figuring out it was based on pictures, and it wasn't actually looking at the main content of the picture. It was looking at the background, and the background actually changed between the two. And so it was doing a pretty good job of discriminating, but the AI was actually looking at the background and not looking at the meat of the picture. Are we able to do any diagnostics or any sense to figure out if the result is truly from what we think it should be?
Yeah, that's a good point. When we extracted, when we go to be to deeper layer of the CNN of the model, uh, the AI was looking for the important feature, as you say. But yeah, sometimes it's looking for like the feature are not refer exactly to the pattern that I mean the scar. They may be looking for the anatomy of the heart. So I can say that these are like the background. Because there is this kind of feature actually important for edema to classify, but I was pick that one was very close to my my ground truth, and because when we change the heat map and the contour, like the image was contoured by the expert, I mean, around the scar and around the edema. I changed them to the binary mass and then compare it with the dice and the like the correlation to make sure they have important. They like refer to the importance of pathology information. I'm not sure if I answer your question properly, but yeah, I'd be happy to discuss more about this.
Yeah, no, I think that's helpful. I think it's just trying to figure out, like for instance, that example I showed you, they were actually able to, and I'm forgetting the term for this, but they were actually able to uh, provide heat maps to show what part of the image was actually being used, like what was actually driving the decision.
Yeah.
And that's, I think, to the extent that you can do that to make sure that that there's not some other confounder that, is hidden in this that's actually driving it, that's giving us, your results look pretty good. But anyway, thank you.
Thank you too.
We have a couple more minutes. Girish, do you have any other questions that weren't asked that you'd like to hear tackled?
Sure. One quick one. How long does it take to do this type of to do the MRI? Because contrast free. So how much time are we saving?
For the OS?
Yeah.
Yeah. OS is like first we ask patient for 40 minutes to do free reading. We don't ask to do anything like lay down MRI, just breathing normally. And then for we give them a headset, and for after that like 6 minutes. But we change it like based on our project. We ask patient to do hyperventilation, like breathe in, breathe out, breathe in, breathe out. And after that, we ask patient to 1 minute to just hold the breath. And exactly during the time that we ask patient to do hold the breath, we take that image, and the whole point of these OS is that during the breath hold, that is look like the LGE, like is like exactly happened what we get fMRI from the brain. We ask patient to do something, and that's part of the brain. That's the network was like works better, and we can see highlighted in the fMRI. And this has happened exactly in the heart when we ask patient to do this OS breathing maneuver.
Okay. So it takes about the same amount of time. It's just the breath holding maneuver.
Yeah.
Yeah. Okay. And then the final question is, what is the next step in terms of this project? Do you have any plans for external validation?
For the OS, yes, but as I showed you, I'm now after that was working on the GAN. So we're thinking that to merge all these network we have, and also because we recruit more patients, we want to add these patients to the network and retrain the game and play with the model.
Okay. Thank you.
Thank you.
Amazing. Thank you both for asking so many great questions to our presenter. At this point, we'll move on to our second presenter. Kejah Bascon is a PhD candidate in mechanical engineering at University of Toronto's Robotics Institute. She completed her undergraduate degree in cognitive psychology at Carleton University in Ottawa, followed by a master's degree in neuroscience. Her research interests include neurosurgical robotics, and she has been recognized as a recipient of the Indigenous Black Engineering and Technology IBET Momentum Fellowship. And over to Kejah to just begin her presentation.
All right, hello everyone. My name is Kejah, as previously mentioned. Today I'm going to be presenting a in-progress project from my current lab at UAT. The project focuses on the investigation of individualized patient education materials on comprehension, satisfaction, and trust. More specifically, we'll be focusing on the use of personalized immersive education tools powered by generative AI and extended reality with a focus on total knee arthroplasty patients from underserved communities. Just to ask everyone, can you see my slide okay? Perfect. All right, I'm just gonna wind a little bit more. So let's get into the conversation about the problem with informed consent. I'm going to start off by explaining briefly about what informed consent is, and then moving on into some of the barriers that pop up when informed consent is being administered. So informed consent is a legal and ethical requirement. Patients should know what the procedure is, what alternatives exist to their procedure, whether they be other surgical alternatives, medication alternatives, other forms of therapeutic alternatives that are involved in the whole entire process, and also what the risks are of these processes, procedures, etc. But in practice, many patients, especially those from equity-seeking groups, leave their consults a bit more confused. Barriers include complex medical language, cultural hierarchies between doctors and patients, anxiety, and a lack of subtle resources. Written forms also feel often inaccessible, and this undermines the true informed consent process and can lead to poorer health outcomes, given that the decision-making may not be up to par due to their confusion or lack of trust. So why does this matter? So when patients don't understand the procedure, they often feel anxious or disengaged from the whole entire conversation. This can lead to a decision that they may regret in the long run or can be avoidable regarding complications due to these misunderstandings about aftercare. So the format of education also matters significantly. Research shows that patients retain far more information when visuals are included versus when reading is alone. This makes sense just given that our visual processing systems are much larger than our reading systems, just to put it simply. So adding those visuals make things much more engaging. So improving how we communicate, not just what we communicate, is important to better equity and better patient outcomes. So for my study, or for the lab study, our proposed solution is one, implementing something like generative AI. So for example, using ChatGPT to add that extra support to the consent forms. So taking pieces of that information and making it into more digestible parts, and catering it more for the culturally appropriate language of the patient, for example. Another thing that we're looking into is using visual AI generated tools. So things like custom illustrations that may match the person's identity as well as the procedure. Again, including that visual component to make it easy, to make it more easily digestible for the patient. The third component that we'll be researching is the use of extended reality. And this will include something where we thought of to potentially immerse the patients in interactive 3D simulations of what to expect during the surgery and after the surgery, for example. And how we see this overall is that together, these tools can deliver a more clear, empathetic, and engaging conversation that will adapt more to the patient's background. So just to give a brief example of this, let's say the patient may not speak English, for example. English is a common language spoken in many of the clinics here, and there may not be access to a translator. So what we hope, for example, using the generative AI, we can potentially rewrite these tools in the language of the patient. We also implement our second point, which is the visual AI generated tools, which will be pulling things like, for example, how a knee surgery may look like, maybe some photos of like a surgeon, maybe, holding some of the tools. We haven't exactly laid out the logistics of that yet, but that's just kind of like an idea that we've been brainstorming. And then third, that extended reality component, which again is something that we're still brainstorming. We have to go out and do some user interviews. I'll pop into our methodology in a second. Using some form of AR or VR tool to help the patient understand what the procedure will actually look like. So maybe add a background of an OR, see how they'd be set up, maybe add a background of what tools will be used, etc., just to add more comfortability in that sense. So moving on, so phase 1 is our needs assessment. We want to identify both patient and physician needs in the context of better education for orthopedic surgery, more particularly for the total knee arthroplasty. So we're focusing on 2 populations with well-documented health literacy barriers and lower satisfaction with surgical education. These include individuals that are from China, as well as from Africa, the Caribbean, and also West Indian individuals. We may expand our population focus groups, but as for right now, this is what it's going to be just for feasibility wise. And then we will speak to patients and a cross section of professionals involved in care. This will include orthopedic surgeons to occupational therapists to better understand expectations, cultural beliefs, and information needs. So our semi-structured interviews will cover several key themes for patients and families. We want to explore their learning preferences, misunderstandings, as well as cultural beliefs. So this includes trust in the medical authority or attitudes towards pain and recovery, because that is also an important component. And for the healthcare professionals, we'll explore what patients often get wrong, what resources they currently use, and how patients interact between consultations. And together, we are hoping that these insights will shape how we design educational content that will resonate with the actual need of the patients, as well as the care providers. So for impact and what's next, so once we complete phase 1, we'll use those insights to prototype patient-facing content. These include tailored documents, the visual assets that I was talking about, as well as the immersive XR elements. We'll also evaluate these prototypes using Lay's model. And just a brief explanation of what that is for those who don't know. This model emphasizes understanding, satisfaction, and recall as core indicators of effective health communication. And our long-term goal is to create tools that are scalable and equitable that will help all patients feel more informed, respected, and confident in their care decisions. My presentation was quite short, so I'm going to thank you all for listening to it and move into questions. And here are my references.
Great presentation. Very cool to see what you're working on. Starting with our adjudicators, from Matthew or Girish, are there any, oh, there's my video. Are there any questions for this presenter?
I have a couple questions if Matthew doesn't want to go first, but I'm happy to go first.
Up to you. Go ahead if you'd like.
Sure. Okay. All right. Thanks, Matthew. Thanks, Kejah, for that presentation. I think it's really important. And I'm a surgeon and I obtain consent all the time, so I understand the value of this. And I think Matthew will say the same, because I think he said he's an ophthalmologist. But a couple of questions. One is if it's an individualized approach that will be provided to each patient, how does someone screen, or is there a plan to screen the actual content? Because if it's coming from the web or multiple sources, how do we know it's accurate for each individual?
All right, so what we plan to do that I didn't include exactly in my presentation, just given the time and it may have been a bit too long to explain, we do plan to do a screening process prior to that, once we get to that point. So that'll be screening actual materials. Hopefully that we filled out a really long REB to try and get access to actual consent documents, as well as the ability to screen patients for the particular procedure that they're getting. Well, we're focusing on total knee arthroplasty, so maybe not necessarily the particular procedure, but their specific needs. We're not looking to do that for phase one, but we do have a prospective idea to engage in that for phase two, where we start prototyping, building the tools, running these tools in actual clinics, developing the AR or VR reality background in something potentially like Unity, for example, and seeing how this will actually play out in actual clinics. I hope that answered your question. I can expand if necessary.
And then just one follow-up question. How will you reduce bias in what is produced based on the sources that you have?
That's a very good question. So what we hope to do is really try and make everything as open-ended as possible and not necessarily add too many identifiers in terms of the generated output. So let's say like we're going to put in patient feels, let's say language barrier here, translate it here, patient has this mentality towards this, put this out like that. We're not hoping to necessarily put in like, you know, every single little bit about the patient, because that causes bias and skewing of our data, because again, it's not being open-ended, it's being very specific. So that's how we're trying to alleviate that. It's going to be very difficult given, you know, we're trying to personalize these materials, but also get these materials hopefully out into the clinic. So that is one way that we're thinking about doing it. There may be other ways where we'll modify, but as it stands for phase one, that's what we're thinking about.
Okay, excellent. Thank you.
Yeah, you're welcome.
Yeah, I'll just echo, you know, as a surgeon, this is so important. And it's tricky. You know, we have patients who are basically like, doctor, tell me what to do. You're the doctor. And they're almost like saddened, concerned if we start like trying to inform them. They're like, what do you mean? You're the doctor. Like, why are you asking me questions? And then we have the opposite, where they bring in the drug monograph of the 4 medications I prescribed and want to go into detail on, you know, the potential for a cardiac arrhythmia, which I've never seen before, in a medication that's listed in the monograph. So we have this problem. I think Dr. Kulkarni has already just addressed, and Mithin also asked a good question. You know, like how are we going to you know, measure this? And that's where you kind of alluded to it, trying to figure out. And this, I think this is going to be harder for it to come up with a gold standard than our first presenter, who, you know, is, again, I'm not in the cardiac realm, has a reasonable gold standard. Here, it's tough. The other issue is, so back to that first patient who's like, I don't want to know anything, doctor. Just tell me what I'm going to do. Where do I sign? Right? I think our feeling in society is that's not enough. Just because the patient tells us they don't want to hear about anything, I think we're feeling like you still have to tell them some part of the risk, because at the end of the day, they might say, or their family, you know, I've had family members too say, wait a second, I wasn't there. I didn't hear it. It's like, well, I talked with grandma about it, you know, because grandma's the patient. What happens if you come up with a model and it decides this is what the patient wants to hear, but our feeling is that's not enough for informed consent? So again, you personalize it, you customize it, and the patient is like, I love this. Just like I said, the extreme is the patient who just wants the doctor to be this authoritative kind of figure that just tells them what to do. What kind of measures do we have to make sure that the physicians and our system is happy with the depth of the informed consent process?
All right, so that's a really good question. I've gotten this question, a similar question when I spoke about this project to like one of my mentors. And the interesting thing about this is that this is to assist the doctor in providing informed consent. So at the end of the day, it is the doctor's decision to make that final choice of what is best appropriate for their patient at the end of the day. It's not that dependability on the AI generated tools or the AI generated visuals or the XR applications, right? It's at the end of the day, it is the physician, and they are to go through the outputs to ensure that this is clear and this information is accurate. Because as we know, generative AI, it hallucinates, puts out things that may not be necessarily appropriate for the patient. The doctor doesn't review it. They just give it to them. They're going to then say, okay, this is great, but, right? So as they're giving these personalized materials, it's also important for the doctor to step in when necessary, and also because they would know their patient better than a chatbot would know their patient. So to step in where they feel it's necessary to provide that extra support to that output or to that AI generated image or to that, that session of virtual reality. Did I answer your question clearer, or do I need to add some more clarity?
Yeah, no, I think that's the realm, and that's where these mixed methods, that's where these are tricky. So you don't really have a good gold standard. So you have multiple things you're going to compare against. You don't really have a gold standard to compare against
No.
unless you're going to consider whatever the doctor does, and then there's a lot of variation by specialty, even by physician. And then you have to have some metric to make sure that there's no hallucinations or under or over reporting of complications. We did a study where risk communication for cataract surgery. There was a huge difference in saying there's a 1 in 1,000 chance of having a complication versus a 99.9% chance of having success. So if you present it in those two different ways, it's why lotteries do so well, right? If you present them in two different ways, the perception of risk for the patient was fundamentally different. So like you said, you kind of have doctors, which are the quasi gold standard that is going to be very hard to quantify. And then very subtle things can affect. So any alteration in how the generative AI comes up with it. So anyway, I think you got your work cut out for you. I think that's the hard part here. That the actual content is amazing. It's just now, because again, we have our own biases. The AI might figure out things that I'm not going at a certain angle in a particular demographic, for instance, that I should be in the AI, as you said. I like the word decision support tool. I think you were kind of alluding to help me to like find my own blind spots. But then is it going to cause all kinds of other, problems?
Yeah, that's for sure going to be the major difficulty when it comes out to applying these tools. Just to add on to, just to extend your question a little bit further, one thing we do plan to do is use one of the reading scales, like the Flesch-Kincaid reading scale, just to ensure that the output generated from these support tools are appropriate for the reading level of the patient. So not at necessarily the college level of reading, but a little bit below that, so it's more digestible. So that's another way that we're going to be incorporating some actual metrics that are pulled from research into our phase 1.
Awesome. All sounds great. There's one question in the chat, which I think you've addressed to some extent, but if you want to address it a little bit more as well, the question was, how do you plan to measure the impact of these personalized education tools on patient outcomes and trust?
All right, so that's going to be more of a phase 2 part of our project. But what we have, the contemplation that we have in terms of what we're going to be using will for sure be some form of scales allowing the patient as well as the physician to give their opinions on how they feel the tool is, how they feel the outputs are, and etc. We haven't isolated the exact survey tools that we'll be using yet, or exactly how we're going to be statistically analyzing this, but it's for sure going to be a mixed methods design, whether it be, a comparative analysis. It will include a comparative analyses, but in terms of how we're going to compare and what we're going to compare, we don't exactly know yet because we're not at that point. I hope I answered your question to a certain degree, but that's where we're at right now in terms of the phase that we're in of our experiment, or our study, I should say.
Okay, amazing. Very cool. And one more question. This might fit a little bit more into the phase 2 thoughts, but I'll ask it anyways. I was curious how you envision what you're working on fitting into the workflow of providers. Sort of where are these tools going, and are they replacing, augmenting, that kind of thing?
So they're not replacing, they're more of an assistive tool. So it's to assist the provider in the informed consent process, absolutely not to automate or replace them, right? Like we're not at that point, even in the technology that we're planning to use, to even put that as, oh yeah, we totally trust this to completely replace the whole process. So it's to assist the physician in providing these tools in a way that supports patient comprehension and understanding. And what we're hoping out of this is that through that increased patient understanding, as well as their comprehension of the materials, the procedure, et cetera, that trust is going to increase. Now, we can't guarantee that trust will increase based on these factors. We can get a really good output, physician is communicating great, the patient, everything's going well, but it may not necessarily increase that trust. There are psychological factors that will go beyond what we necessarily are looking at, but we're hoping that including this in the workflow as an assistive component will at least help build these factors that we're looking at.
Amazing. Well, maybe we will wrap up a couple of minutes early if there aren't any other questions from either of our adjudicators or the audience. No. Yeah,
No, I'm good. Thanks.
Okay, perfect. In that case, thanks to both of our presenters for their great presentations, and thank you to our adjudicators and everyone else here for attending and listening to these presentations. Have a great afternoon.